So to start off with, we have Dr. Spero Manson, who's a distinguished professor of public health and psychiatry and director for the Centers for American Indian and Alaska Native Health, and occupies the Colorado Trust Chair in American Indian Health within the Colorado School of Public Health at the University of Colorado. Dr. Manson, we certainly would love to hear a little bit about the work that you've been doing with the Native communities, and can you share your perspectives on community context and social?
Of course. Thank you very much, Liliana. And David, thank you for your wonderful opening remarks, setting the stage for us and the prior panelists. I'm going to begin by underscoring again Bernadette's introduction to the audience of the forthcoming article that issues from the NINDS working group on health disparities and inequities, led by Dr. Derek Griffith and others of us, titled Determinants of Inequities in Neurological Disease, Health, and Well-Being. The latter portions of that title, I think, anticipate many of the key elements that were suggested by the prior panelists that we deserve our emphasis. It will be forthcoming very soon in neurology, and I think it provides a wonderful framework that is practical in its application. Bernadette provided a slide that showed it schematically. But more importantly, unlike many of the frameworks that have been offered over the last decade or so around such matters, this one is linked to very concrete recommendations for research priorities in the context of community and the engagement of our constituencies. So I highly recommend it to you. It is multidimensional as well as multi-level in its focus. And it, as Bernadette anticipated, has both upstream and downstream implications to it. And equally important, and I'll come back to this in a moment in my closing remarks, it emphasizes a transition, or at least an expansion, from a largely person-centric orientation, which our disciplines have been characterized by in the area of CNS disorders and the research related to that, to at least an equal attention to the sociocentric aspects of CNS disorders, both understanding risk protection as well as prevention and intervention. So my focus, no surprise, is with American Indian Alaska Native communities. And I want to point out in the context of this particular population of interest that there are three major conditions of greatest concern that fall within our current landscape. The first has to do with Alzheimer's disease and related dementia. Now, Dr. Williams focused on life expectancy. The audience may not realize that in 1970, the life expectancy of an American Indian, male or female, was approximately 47.5 years of age. And as of 2019, it had risen to 71.8 years of age, still almost 7 years less than their non-Hispanic white counterparts. Equally importantly is that more than any other subpopulation over the 2.5-year pandemic, we lost, that is American Indian Alaska Natives, declined by 4.6 years of life expectancy. So we experienced a dramatic regression in that regard. What are the implications of that for Alzheimer's disease and related dementia? Alzheimer's disease and related dementia were largely—
Recording in progress.
Were largely unaware and non-existent in the 1970s because of the life expectancy of most Native people. But with that advancing and increasing life expectancy, we saw the explosion of what we come to call the diseases of Western civilization, largely diabetes and cardiovascular disease, which we know are major risk factors for dementia. And so we have seen at least an 8 to 10-fold increase in the prevalence of ADRD, Alzheimer's disease and related dementia, among Native people as a consequence of that. The second major condition of concern for us is acute spinal cord injury. I may not realize this, but the highest rates of acute spinal cord injury are among American Indian Alaska Native people, largely as a function of the environments in which many of us live. Imagine, for example, the high rates of motor vehicle accidents due in large part to the poor road conditions and the socioeconomic circumstances that surround driving in Native America. It's no accident that we see, for example, in Arizona, New Mexico, Oklahoma, the Dakotas, and Montana, rates of motor vehicle accidents and concomitant increase in spinal cord injury anywhere from 4 to 8 times their non-Hispanic white counterparts in those same states. And then thirdly, a focus on traumatic brain injury, TBI. Traumatic brain injury, of course, among American Indian Alaska Natives, notably among the military personnel and now our veteran population, is substantially greater than any other subsegment, and because of the nature of exposure to combat and the like. But that is also true in terms of exposure to the high rates of interpersonal violence that lead to physical injury and often TBI. So those are the 3 conditions of greatest interest to us with respect to American and Alaska Natives. But we have to situate this from our point of view in the context of access or relative inaccess to appropriate prevention and treatment. Matters of awareness, affordability, availability, and acceptability of the various services that are broadly available to other segments of our population, urban or otherwise, are typically not available to Native people. And we have to pay particular attention to the structuring and financing of those services. And lastly, as Dan and Bernadette and Dr. Williams pointed out, let's not forget matters of strength, assets, and resilience, because indeed there are those well springs of resilience in Native communities that do make a difference in terms of both risk and protection and ultimately coping with the consequences of CNS. Thank you.
Thank you, Dr. Manson. Thank you for sharing your work and certainly concerns within this community and leading with a positive ending, which is very true about learning about the resilience and coping mechanisms. Could be certainly thoughts of interventions or opportunities.